All right, so let's get started, everyone. Good morning. I'm so happy to welcome you guys to this webinar this morning. We'll be talking about great cases in old disease with many different faces. And I'm happy to welcome our speakers, Dr. Bravo and Dr. Human. So I'm Esther Nuozo, and then Akachi is our other host today. So we are with the Gloderm Training Committee. So a little bit about us is that the Gloderm Training Committee is a part of the ILDS, which is the International Alliance for Global Health Dermatology under the National League of Dermatologic Societies. So our mission is to promote knowledge equity by enhancing access to dermatology education worldwide. So some of our key initiatives are educational webinars, so providing these free high quality learning opportunities, as well as networking and collaboration, so connecting trainees worldwide, as well as providing a podcast series to address challenges in global health dermatology. So a little bit about our meeting etiquette. So your audio will be muted and then your camera will be turned off for the duration of this webinar. Please submit any questions you have via the chat or the Q&A function. And then I, myself, and then Akachi will also share these with the speakers to answer at the end of the webinar. Also, we will be sharing further information about the Gloderm Training Committee in the chat as well. Okay, so our speakers. So Dr. Bravo is a Peruvian dermatologist and dermatopathologist based in Peru, and he specializes in the clinical and histopathological aspects of infectious diseases, tropical diseases, as well as viral-related lymphoma and acral melanoma. His expertise has been recognized through different collaborations and several chapters on infectious diseases within dermatology textbooks, including Fitzpatrick and Bologna. Currently, he serves as an associate professor of dermatology and pathology in Peru. And then Dr. Human is a dermatology resident also from Peru, currently training at the hospital there. She also has a strong interest in clinical dermatology, dermatologic surgery, and cutaneous oncology. And through her academic and clinical work, she aims to improve dermatology education and improve access to care. All right, you guys can take it away.
Good afternoon, everyone. Today, I'm pleased to present 3 clinical cases of an old disease with many faces. Let's begin with the first clinical case. This is an 83-year-old man from Chimbote, a city located in the north of Peru. He referred a 3-year history that began with an ulcer with a central hemorrhagic crust on the xiphoid area. 1 year later, he developed around that ulcer an erythematous plaque with serous discharge. That then extended to the thoracoabdominal area. When he arrived to our service, he referred weight loss, and on physical exam, he appeared malnourished. On the skin on thoracoabdominal region, he presented an erythematous plaque with verrucous borders and in the center a extensive scar. Also on xiphoid region, he presents a 2 centimeter ulcer with erythematous borders, retractile scar in the center, and a hemorrhagic crust on the surface. On dermoscopy, we observe some whitish streak, erythematous structure over a yellow-green background. These findings are compatible with granulomatous disease. So, what diagnostics should be considered? In this case, the main differential diagnoses are lupus vulgaris, chromoblastomycosis, paracoccidoidomycosis, blastomycosis, and squamous cell carcinoma. We perform this diagnostic workup. On laboratory tests, the patient presents mild anemia and elevated acute phase reactant. Serological tests were non-reactive. Tuberculin skin test was strongly positive with an induration of 18 millimeters. The smear for acid fast bacilli made on sputum were negative, and we performed an skin biopsy in the border of the plaque. The epidermis was slightly hyperplastic, and on dermis, we observed an inflammatory infiltrate composed of lymphocytes, plasma cells, giant cells that form epithelioid granulomas. Also, on deep dermis, there were nodular aggregates of lymphocytes, and at higher magnification, we observe lymphocytes and some giant cells. We also performed mycobacterial culture, and it was positive for Mycobacterium tuberculosis complex. This also provides us the antibiogram profile, and on chest CT scan, we found biapical retractile pleuroparenchymal retractions with associated calcifications that suggest a previous pulmonary tuberculosis. Also, in mediastinal window, there was an apparently blind tract of 12 millimeters that reaches the last chondroesternal joint space of this size. This suggests a communication of the skin with the chondroesternal joint. We start treatment with a drug-sensitive regimen for 12 months, and after 2 months of treatment, the patient presents a clinical improvement. So, with clinical morphology, granulomatous histopathology, positive mycobacterial culture, and imaging findings, we conclude with a diagnosis of cutaneous tuberculosis, lupus vulgaris secondary to scrofuloderma. Continuing with the second clinical case, this is a 92-year-old female from Ancash, a city located in the highlands of Peru. He referred a 6 months history that began with a nodule near the lateral canthus of the left eye. Then she developed another nodule in the left preauricular area, while the first nodule evolved into a scar. And then she developed new painful nodules. When she arrived to our service, she referred fatigue and also weight loss. On past medical history, she was hospitalized for pneumonia some months before. On physical exam, she appeared malnourished, and these photos were provided by the family in a representative of the beginning of the disease. The initial lesion was a soft and fluctuant nodule with mild overlying erythema. This lesion was a cold abscess. 1 month later, she developed a second nodule in the preauricular area. This nodule became more tender and discharged hemorrhagic content. When she arrived to our service, she presented a verrucous plaque in the infraorbicular area that present some retractile tissue and crust, and on dermoscopy, we also observed some erosions. In the preauricular area, there was a ulcerated verrucous plaque. So, what diagnosis should we consider in this case? Let's remember that this patient presents 2 ulcerated verrucous plaques that have a special distribution, lymphatic or sporotrichoid pattern. In this case, we must consider the main differential diagnosis: sporotrichosis, leishmaniasis, tuberculosis, non-tuberculous mycobacteria, and deep fungal infection. So, we perform this diagnostic workup. On laboratory tests, serological tests were non-reactive. Chest X-ray shows an heterogeneous consolidation on the base of the right hemithorax that was consistent with the past medical history of a pneumonia, but it doesn't show signs of pulmonary tuberculosis. The smear for acid-fast bacilli made on sputum were negative, but interferon gamma release assay was positive. On the skin biopsy, show epidermal hyperplasia with a pseudoepitheliomatous area. In dermis, there was an inflammatory infiltrate composed of lymphocytes, plasma cells, giant cells, and also some neutrophils that form suppurative tuberculoid granulomas. Also, at higher magnification, there are some giant cells. The fungal culture was negative. Autoimmune stain from the skin biopsy also was negative. Non-tuberculous mycobacterial PCR was negative, but mycobacterial culture was positive for Mycobacterium tuberculosis. So we start treatment with a drug-sensitive regimen for 12 months, and when she completes all the treatment, she presents a complete resolution of skin lesions. In this case, with clinical morphology, histopathology findings, and the mycobacterial culture, we conclude with a diagnosis of cutaneous tuberculosis, ulcerated plaques with sporotrichoid pattern. Finally, the third clinical case. This is a 36-year-old female from Lima, Peru. She referred a 24-month history that began with two erythematous papules on legs. These papules evolve into nodules that then resolve, leaving hyperpigmentation. The patient refers also new lesions with similar characteristics in the last 6 months before she arrived to our service. She denied constitutional symptoms. On past medical history, she refers appendicectomy and denied history of contact with a person with tuberculosis. On physical exam, she only presents lesions in the skin that were located in both legs. There were tender erythematous nodules. These nodules were more palpable than visible and leave hyperpigmentation. So what diagnosis should we consider? In this case, we have painful nodules on the lower limbs. So the main differential diagnoses are erythema nodosum, erythema induratum of Bassan, and polyarteritis nodosum. We performed this diagnostic workup. Tuberculin skin test was strongly positive with an induration of 25 millimeters. The smear for acid-fast bacilli on sputum were negative. On chest X-ray, there was no evidence of active pulmonary tuberculosis. And on the skin biopsy, the main findings were located on subcutaneous fat. There was a moderate inflammatory infiltrate composed of lymphocytes, plasma cells, giant cells that form tuberculoid granulomas. We start treatment with a drug-sensitive regimen for 9 months, and after 6 weeks of treatment, there was a clinical improvement with a decreased inflammatory activity of nodules. The patient denied new lesions, and there was only some hyperpigmented macules. So in this case, we conclude with the diagnosis of erythema induratum of Bassan, a type of tuberculosis. Thank you. Now, Dr. Bravo is going to make the revision.
Good morning, everyone. My name is Francisco Bravo. Thanks to Derm for the invitation, and thank you to Victoria, who had made a wonderful presentation of the kind of cases we want to discuss. You already know we are talking about cutaneous tuberculosis. Tuberculosis is still a worldwide health problem. 1.7 billion people are infected. 10.8 million people had tuberculosis in 2023. And 1.2 million deaths have been caused by tuberculosis in non-HIV patients. In HIV patients, there is another 251,000 people die. In infectious diseases, tuberculosis is the second most common cause of death due to an infection after HIV. And in fact, both diseases can present at the same time. Peru has about 33,000 new cases of tuberculosis every year. And in Latin America, Peru is only second to Haiti in the incidence of tuberculosis. with around 140 to 170 cases per 100,000 inhabitants. Cutaneous tuberculosis is not that common. It's about 1.5% of all forms of extrapulmonary TB. But to see all forms of cutaneous tuberculosis, you must live in a country with a high incidence, which is what happened to us here in Peru. In general, cutaneous tuberculosis has a low bacterial load. And to understand tuberculosis, you have to be a little familiar to the way it spreads. Inoculation, reinoculation, hematogenous spreading, or spreading from an underlying structure. One way to think about tuberculosis is to think a little about it as in leprosy. You have multivacillary forms and you have paucibacillary forms. And the immune reaction goes in the opposite way. The more immune reaction, the most likely you are going to have a clinical expression of disease, even when you have a small amount of bacilli. And that's the way to understand tuberculitis, the tuberculitis. So I'm going to present to you the way we think about tuberculosis. This is a paper that we wrote many years ago when we exposed the idea of multivacillary forms, paucibacillary forms, and minimal amount of bacteria causing disease, talking about tuberculosis. How to make a diagnosis? I think you can construct a diagnosis of tuberculosis by using these 6 points. Number one, epidemiology. Where is the patient coming from? Has the patient contact with TB? And in the world, you have to look at the map and see if your country is prevalent or the patient where it's coming from, tuberculosis is prevalent. And if you see Peru has a high load of tuberculosis, especially in South America. And HIV and TB is actually not so rare combination. For that reason, you have to be even more aware of tuberculosis, cutaneous tuberculosis. Number two, how to make a diagnosis, clinical picture and pathology. And it's going to be impossible for you to make a diagnosis of tuberculosis if you're not familiar with the different clinical forms. The clinical spectrum, again, we'll go first with multivacillary tuberculosis. And the most striking one is the tuberculous chancre, which is the primary inoculation tuberculosis. How can it happen? For example, in this kid is young, may have had BCG, got in contact with somebody who had active pulmonary TB, and either by kissing the kid or something else, the kid developed a chancre, an inoculation chancre, and a lymph node. That will be equivalent to the gum complex that you will see on the lung. This is another case, courtesy of Dr. Ramos, where you see the primary site and a lymph node on the upper neck. And this is a more interesting case when the kid got a ulcerative lesion on the buccal mucosa, on the alveolar mucosa, and then develop a lymph node. This is cutaneous tuberculosis acquired by even a small lesion on the gum, or even by drinking milk contaminated with Mycobacterium bovis. And this will be the more classical case, which is the inoculation chancre of a health worker or a doctor doing an autopsy. Then you have all secondary types, which are anything different than the primary inoculation. And in here, I will have to make a point of how you can develop cutaneous tuberculosis, either by endogenous propagation. For example, in a scrofuloderma, is by continuity from a structure, underlying structure, such a lymph node. You can get hematogenous spreading, so you will get gammas or cold abscesses. You can get self-inoculation from contaminated sputum, contaminated feces. That's called perioral tuberculosis. You can have it on the mouth or on the anus. You can have hematogenous spreading in somebody who is immunosuppressed. You will have cutaneous miliary tuberculosis. You can have endogenous spreading of tiny amounts of bacilli on the face, and then you develop lymphatic spreading, and you will have lupus vulgaris on the face. Or you may have very early in the infection, endogenous propagation by hematogenous spreading. End up with these tiny amounts of bacilli all over your body. But your immune system is able to control it until many years after there is a failure of the immune system, and then you get what is called the tuberculosis, which is a strong immune reaction to a small amount of bacilli. And then you can have exogenous TB, where you have a high, strong immune reaction. You get a tiny amount of inoculation of the bacilli on the skin, and then you have a lesion that expresses contention of the infection in a small area, either the extremities or even beyond that. And that's the case for tuberculosis verrucosa cutis and lupus vulgaris on extremities. Now, let's see examples of each of them. Scrofuloderma, neck, usually on the neck. Underlying structure, the lymph node. These are typical cases of scrofulodermas on the neck, which is in Peru the most common presentation of cutaneous tuberculosis. You can have draining from different sides, like the example that Dr. Huaman showed. Somebody who had a osteomyelitis or chondritis on a joint on the chest wall, and then start draining and then develop a lupus vulgaris, or somebody who had it in the abdomen from peritoneal TB. You can have gammas. Gammas are cold abscesses that you get from spreading. And many gammas, like the lady on the second case, are usually from bloodstream spreading. By the time you see the abscess already opens and is looking like an ulcer, like this case or this case. And then you have a very particular type, which is locally known in Peru as snuff box TB, which is a cold abscess from inoculation, reinoculation. Let's see these two cases. This patient had active pulmonary TB. How did he end up having TB on the arm? What do you do when you cough? You cover your face either with your hand and your arm, and you have an inoculation of TB. And that happened in this particular case, giving you a sporotrichoid pattern, or this particular case, courtesy of Dr. Alvarez, who developed active abscesses either on the arm and the hand. And the patient had pulmonary TB at the same time. He was even on treatment when he developed this. The cultures and PCR done on the lung and the abscesses on the arm were positive for Mycobacterium tuberculosis. You can have periorificial TB. This is a man that I saw many years ago, had active pulmonary TB, and came to the clinic with a plaque, a verrucous plaque on the mucosal area, on the buccal mucosa. he didn't have any pain because the lesions were not ulcerated. But if he had an ulceration, like this HIV patient with this opening ulcer with undermined borders and multiple lesions looking like acrocordons, but they are actually granulomas, this is very painful, and this is anal periorificial tuberculosis. Paucillary tuberculosis. Lupus vulgaris, the one on the face, the classically described in the old books. This is the picture of an old book from Europe in the 1800s. And this is the kind of case we see once in a while at the hospital. This is lupus vulgaris on the face. First, hematogenous spreading, small lesion, and then lymphatic spreading all over the face. In this particular form, the granulomas can look sarcoidal. And if you look very careful, you are not going to see necrosis or calcio-necrosis or neutrophils. These are usually long-standing lesions. And that was the case of this patient who had already like 20 years of evolution. It started on the right face and expanded to the whole cheek and leg and neck. You see, this is what was described of the jelly, apple jelly appearance. When you use dioscopy, putting a glass slide on top of the skin, or dermoscopy, which is what we use here. What happened with the patient got treated, the lesion became just a scar. Lupus vulgaris sometimes occurs where areas where you previously had some sort of cutaneous tuberculosis. It can appear in an area of a BCG vaccine. It can be appearing in an area of scrofuloderma, or like the case that Dr. Huaman just showed you, or in an area of previous cutaneous periorificial tuberculosis. Let's see this case. This case presented with lupus vulgaris on the inguinal area. But if you look carefully, he had scars. On the other side, he had the scars because he had scrofulus before. This kid also can be explained by the same mechanism. At some point, he had genitourinary tuberculosis, he got scrofulas, the scrofula solved quickly, and then many years after, he developed lupus vulgaris on the areas of the scrofula. And this is a not so uncommon presentation that we have seen. This is cutaneous tuberculosis, looking like lupus vulgaris, on the gluteal areas, because they had at some point a small amount of periorificial tuberculosis. There's not only one, but 2 and 3 and 4 cases. Paucibacillary cutaneous tuberculosis. This happens when you have a very strong immune reactivity and you get inoculated in one single point. I can show you cases where this happened on the hands, or when can happen on the soles. And for example, this is a plaque, verrucous border, central atrophy, and scarring, looking like the patient that Dr. Victoria just presented to you at the beginning of the discussion. Another case, sometimes what's the inoculation due to the fact that the patient manipulates beef, meat, like butchers or cookers, or somebody who is working on the fields, working with cows and milking the cows. And then you get Mycobacterium bovis in eliciting the same immune reaction in a patient who already have good, strong immunity against Mycobacterium tuberculosis. This patient works in a slaughterhouse and developed cutaneous TB on both arms. You can have it on the soles. One single sole involved. These are 2 different patients. And how do you get it on the soles? You got a strong PPD reaction. You have a strong immunity. You walk barefoot in some contaminated soil. You get one single or two single bacillus, and your immune system is able to contain the disease in one single place. This happened in this particular case. Tuberculosis verrucosa cutis is very similar to the first one. The only difference is that you have such a strong reaction that your skin is mostly hyperkeratotic on top of the plaque. So you can have it like this, which is a patient that has tuberculosis verrucosa cutis and is a butcher, or you can have it in this patient from remote areas of Peru, where he works on cattle, and milking the cattle will produce this disease or this disease. The concept of tuberculosis is probably the more difficult to understand. Why you will have something like a paniculitis? Just to tell you the concept of tuberculosis, it's an inflammatory immunological reaction to a minimal amount of bacteria, alive or dead, that function as an antigen. There are even more forms of tuberculosis, but the ones that are widely accepted are erythema induratum of Bazin. Bazin was a French dermatologist in the 1800s who described the disease before Mycobacterium tuberculosis was isolated, but he could make sense of the kind of presentation you're going to see. Papillonecrotic tuberculosis and lichen scrophulosaurum. To explain this, you have to know something. When you get the infection with tuberculosis, there is early dissemination that is very extensive. But what happened is that the amount of bacilli is so small that can get dormant and don't show up clinically until many years after. That will explain the occurrence of tuberculosis. And early dissemination is very likely, very possible. Erythema induratum of Bazin. Nodules, mostly on the posterior aspect of the legs, that usually became ulcerated. Main differential diagnosis, erythema nodosum, because erythema nodosum are non-ulcerated nodules on the anterior aspect of the legs. To be honest, they overlap. So sometimes you will see the clinical findings of erythema nodosum and the pathology findings of erythema induratum. And the histology is very classical. It's a lobular paniculitis with granulomas, necrosis, and vasculitis of some degree. 3 out of 4 granuloma, necrosis, vasculitis, and a lobular paniculitis, 3 out of 4 will make your diagnosis. And of course, a positive PPD. Papillonecrotic tuberculosis, tiny papules, usually umbilicated on extensor areas of the extremities in somebody who have or may not have pulmonary TB at the same time. The presentation is like this, multiple papules that are umbilicated. And if you do a biopsy, you will see a V-shaped necrosis with granulomas and vasculitis. And lichen scrophulosaurum, lichenoid reaction, that's the reason it's called lichen, because they are papillars similar to lichen planus. And look at this patient. Tons of little tiny papules everywhere. Lichenoid, like lichen nitidus. But the patient has lymph node disease. He had TB on the epitrochlear lymph node on the right elbow. And clinically, that's the picture. Histologically, if you biopsy that papule, it's a granuloma. It's an epithelioid granuloma with no necrosis, usually associated to a follicle. Very unlikely for you to see bacilli on the biopsies of tuberculin, because again, it's more the immune reaction than the amount of bacilli. So there is different identifiable histological patterns. You don't always have to see casein necrosis. The common denominator is you always see a granuloma, but sometimes can be suppurative or sometimes epithelioid, sarcoidal, and it may ulcerate or may not ulcerate. But the common finding, a granuloma, tuberculoid granuloma. What else can you do to make a diagnosis? Microbiology and molecular biology. Microbiology, you can do direct exam. It's unlikely that you're going to see bacilli on a direct exam of the pus secretion, but it's most likely for you to see it in gammas. You can culture, and cultures are, we have different cultures available at Cayetano, Lowest and Jensen, MGIT. Sometimes they are positive, sometimes they are not. Most likely, you are going to have a positive culture if you have a type of multivascular TB, like a scrofula or like an abscess. These two first cases that Dr. Huaman presented. But it's going to be very unlikely that you're going to see it in lupus vulgaris on extremities or tuberculosis verrucosa cutis. And you should not expect to see a positive culture in tuberculosis. One good lesson I learned through the years, a negative culture doesn't rule out the diagnosis. You have to think of the clinical form of tuberculosis you are seeing. PCR, great, but it's not standardized for the skin. In many countries, the PCR techniques are available now, but they are standardized for the sputum. You have to talk to your lab and see if they can do gene expert on the skin. Fortunately, they are becoming more adventurous. The biology is working on this. So we have inside probes, and we have local microbiologists that try to use gene expert on the skin. But again, unfortunately, even PCR is not always positive in all types of TB. So you have to construct your diagnosis. PPD, very important, especially in paucibacillary forms. The PPD can vary, but as a rule, PPD is between 10 and 15 millimeter. Even if the patient had already BCG, in the clinical context of whatever form of TB you have just learned, it contributes a lot to making the diagnosis. The IGRA test is very good, but unfortunately, it's expensive and not available everywhere. PPD is a very useful tool, and the combination of both is even better. So what happens if the clinical picture is okay, the epidemiology is okay, you see the granulomas, but you don't have the microbiology or the PPD is scarce where you work? You are in the whole right of trying a therapeutic trial. And that has been tried in India. In India, Dr. Rahman, a friend of mine, published this interesting paper where he sort of proved that if your patient with a clinical picture of tuberculosis respond to treatment after 6 weeks, you are likely right, and you should continue the treatment. Regarding therapy, cutaneous TB can be treated as pulmonary TB. In the case of Peru, we try to leave the therapeutic part of the deal with the national TB program, which assures that the patient will receive complete treatment. In the other hand, even when we have multi-drug resistant pulmonary TB, it is not common to see multi-drug resistant cutaneous tuberculosis. And the standard treatment usually is 2 months of 4 drugs plus 4 additional months of INH and rifampin. It can be extended to 9 to 12 months, and sometimes it's a decision taken either by the program or whoever administrates the TB treatment on your countries. So when diagnosing TB, number one, you have to know the clinical forms. And I hope this lecture can be remembered of that part of the clinical spectrum. You have to know the limitation of pathology. Granulomas, common denominator. You don't need to have caseous necrosis to make a diagnosis. You have to know the limitations of your microbiology lab and even your PCR. You have to know how to use a PPD and an IGRA test. And at least, but not last, you always can look for help by doing a therapeutic trial. So this is the vision of cutaneous tuberculosis that we from Cayetano want to give you after working so many years. And remember, it's a very common disease. If you live in a country where you see a lot of tuberculosis, you have to remember. And if you live in a country where you don't have that many tuberculosis, still you have to be aware, because if you see pulmonary tuberculosis, you're likely to see some case of cutaneous tuberculosis. Thank you very much. And just to let you know that if you are really interested in tropical diseases, we have a course where in Lima, Peru, in alliance with University of Alabama and the Gorgas Institute. There is a 1 week of a course where you actually see patients as well as all the theory around such interesting subject. And thank you very much, and I congratulate GlobeDerm for making this effort.
Thank you, Dr. Bravo and Dr. Huaman. So I'm going to hand it over to Akachi for our Q&A. Thank you so much for your amazing talks.
All right, thank you, Dr. Bravo and Dr. Huaman for the talk. So we have a question from Benjamin. And his question is, in relation to grade cases and the clinical variability of vitiligo, how can international dermatology networks and patient organizations like the ACV, which is the Vitiligo Foundation, support clinicians in recognizing atypical presentations and improving personalized management of vitiligo, particularly in Africa?
We see vitiligo, and I think vitiligo is a subject that should be looked carefully, especially in people living in high radiation areas. In Peru, it happens that we have one of the highest radiations. And for us, the dermatologists working in South America, and probably many of you who are listening to these lectures, we are confronting a challenge because we have to know all the dermatology from people living in more developed countries, plus all the diseases we see in our own countries. We end up knowing more about dermatology in general than many of our colleagues, including vitiligo, skin cancer, many things. We have to learn tropical dermatology plus all the rest of the dermatology. That will be my comment.
We have another question from Dr. Niraj. Said, excellent presentation. Just wanted to know if you could share some tips on differentiating between cutaneous TB and cutaneous leishmaniasis when both of them are prevalent and overlap with histological features.
Sure. Number one, you have to be on an area where you have both diseases at the same time. In Peru, that happens. And it's actually a very common differential diagnosis. When you have a small lesion, an ulceration on the arms, on the leg, and and you see granulomas on the biopsy, you exactly have differential diagnosis for us. I work at the lab sometimes, and you see granulomas. So my differential diagnosis will be leishmaniasis, sporotrichosis, and tuberculosis. Sporotrichosis is easy to diagnose if you have a good mycology lab, because sporotrichosis is very easy to isolate. In leishmania and tuberculosis, both are diseases where you have to use all what you have available, because as opposed to sporotrichosis, with a culture, everything is solved with a culture. In leishmaniasis and sporotrichosis, you have to use whatever you have at hand. The ulcers in tuberculosis are bigger, larger, and sometimes they have undermined borders, not like Buruli, but deeper. Deeper than leishmania, whereas in leishmania, the ulcers are more shallow. And it's hard to see leishmania in urban areas in Peru. I am aware of in the Middle East, it's not uncommon. But again, I will use the clinical picture that can be similar, histology, where TB usually always have granuloma, whereas leishmania, sometimes you don't have a granuloma, but a lymphoplasmocytic infiltrate with some histiocytes. And of course, if you see the leishmania, you have the diagnosis. The intradermal test, the PPD test, would be very good to orient you toward TB, and the leishmania test will orient you toward thinking about leishmania. And then good lab. A good lab is always necessary to make a diagnosis of leishmaniasis. There was some question also about PCR. Does PCR rule out, a negative PCR rule out TB? No. I know that as a doctors, we think PCR is never fails. Well, in TB, does fail. I had seen cases where PCR was negative, and the final diagnosis was cutaneous tuberculosis. So, and PCR depends of your lab and depends of the expertise of your people at the lab using, for example, GeneXpert as a tool.
Okay, thank you, Dr. Bravo, for answering the next question. And then the last question for today will be specific to Dr. Huaman, and this is from Dr. Benjamin Miazzi. And he's saying, within the context of our topic today, how can patient organizations such as the Congolese Vitiligo Association contribute to improving the understanding of clinical diversity and enhancing the patient care pathway in resource limited settings?
Always what is important is clinical. First, we have to make a really good history and always consider epidemiology. Also, that's an important point when we want to differentiate leishmaniasis from tuberculosis. Here in Peru, we always have that difficulty with some cases because we can have a varicose plaque of a long time, and these two are going to be the main clinical diagnose that we are going to consider, but epidemiology is going to be important, and then the clinical, the treatment trial in order to have a clinical improvement after 6 weeks of treatment. We don't have all the time molecular tests or laboratories, but we always try to diagnose with the clinical and the epidemiology.
Okay, thank you, Dr. Huaman and Dr. Bravo, for your insightful responses and for the lecture today. I'm going to transfer it over to my co-host, Esther, to take us off.
All right. Thank you, everyone, for joining our webinar this morning. Thank you so much to both of our speakers. We enjoyed having you and hearing from you. Please follow GlowDerm on social media to learn more about our upcoming events, webinars, programs, and more at GlowDerm Alliance. Thank you, everyone.